Good morning, ladies and gentlemen. Hi, and welcome online audience. Welcome online for the first live grand rounds which is going out of Dr. Agarwal's eye hospital. We chose a topic which was probably one of our favorite topics when we were studying ophthalmology. But as we go into ophthalmology day-to-day practice, it gets highly difficult to kind of remember this if you are not in it 24/7. And the point which we want to bring about in today's topic is what we should do or could do in order to pick up those salient features, those important points in cranial nerve palsies related to ophthalmology. Now, before we begin this very interesting conversation, I'd like a few housekeeping notes. Well, to all the delegates online and present over here currently, I would really request all of you to chip in those questions whenever you have it in your mind. Don't hold back, because we really are interested in holding an interactive session. We really want it to be one of the kind sessions where we can interact and get to know what could be a possibility for a better ophthalmology practice. Now, that's one. Second, speakers and panelists, thank you first for participating in this first live grand rounds. Honestly, it takes guts to come online and talk about a topic such as cranial nerve palsies in front of an audience, especially after more than 10 years of practice, which you all have had. So thank you so much for your time and your knowledge. Keeping to time is very, very important, and we expect everybody to keep to time, especially the moderator, that is me today. So let's begin without any further ado. So can we have Dr.Soundari, who's going to be giving us the lecture on cranial nerve palsies 3, 4 and 6. Thank you, Dr. Soundari.
Good morning, everybody. So today we are going to see how to approach a case of 3rd, 4th and 6th nerve palsy. Even though each one acts differently, we have a common approach to 3rd, 4th and 6th nerve palsy. So history. So what is the history, you will ask? Is there a sudden onset of diplopia? So a sudden onset of diplopia. First of all, you have to ask whether it's a uniocular diplopia or a binocular diplopia. So uniocular diplopia could be because of subluxation or because of keratoconus or something like that. So we are not interested in the uniocular diplopia, we bother with the binocular diplopia. So when the patient closes one eye, the diplopia disappears. That's what we are bothered at. So we are looking at a misalignment between the two eyes. So when there is a sudden onset of diplopia, you think of a nerve palsy and sudden onset of aqueous squint. So far the patient has been orthophoric and suddenly a patient develops a squint. That is the history the patient gives and could be associated with pain. Sometimes severe pain can be there in case of diabetes, aneurysm and all that can lead on to severe pain. And drooping of the lids, which is common in the 3rd nerve, and head tilt. Basically in the case of a 4th nerve, suddenly the patient adopts a head tilt to the opposite side, right? And face turn. Usually in the 6th nerve palsy, the patient has a face turn to the same side. So what are the other histories which we will look at? So we'll ask for history of diabetes and hypertension, which are the most commonest causes for ischemic nerve palsies, and history of trauma. Was there any history of trauma, head trauma, to cause a nerve palsy? Any headache and vomiting to cause an increased intracranial pressure, which can result in a nerve palsy? Any history of blurred vision? Sometimes optic nerve can also be involved along with the other nerve palsies. Any recent viral illness or recent vaccination? Both these can lead on to a 6th nerve palsy. Above the age of 50, ask for prodromal symptoms of GCA. Even though GCA is not very commonly seen, you should keep that in the back of the mind and should ask for scalp tenderness, jaw claudication, polymyalgia rheumatica. All that should be asked for if the patient has a painful nerve palsy and any other cranial nerve involvement. Apart from that, any other neurological abnormalities where the patient has developed. These are the history which you will probe into. So when it comes to examination, as the patient walks into your clinic, obviously you have to look at the patient for any head posture. So that is very useful clue for us to come to a diagnosis. A face turn or a head tilt, and then when the patient walks in, That itself will give you a diagnostic point. Apart from that, you have to check the extraocular movements. This extraocular movements generally we skip. As soon as the patient comes, we put them on the slit lamp and start looking into the eye. We never check the extraocular movements as a routine. Sometimes when we are doing the indirect, we realize this patient is not moving his eyes, and we go back and check the extraocular movements. So I would recommend everybody to check the extraocular movements as a routine. So what are the things which you will check when you are checking the extraocular movements? You ask the patient, do the all 9 diagnostic positions. So in primary position, elevation, depression, dextro elevation, dextro depression, levo elevation, levo depression, dextroversion and levoversion. These are the 9 diagnostic positions. That doesn't end the extraocular movements. Apart from these 9 diagnostic positions, you have to look for convergence. One is convergence you have to look for, and the other thing is saccades. Saccades is one another important thing which is very helpful in cases of supranuclear gaze palsies. And you have to look into the pupil specifically for anisocoria, whether there is a dilated pupil or a constricted pupil. What it is, you have to look in cases of a nerve palsy. The pupil plays an important role. And fundus examination, why? To look for disc edema, to rule out whether there is any papilledema which is causing a 6th nerve palsy. And other cranial nerve examination, any other associated cranial nerves are involved or not, that has to be examined. Apart from the routine vision and other things which we normally do for cranial nerve palsy, these are the important points which we have to look for. So apart from this, I would definitely stress the importance of diplopia chatting. This hardly takes 2 to 5 minutes. We can do it in our clinic. Generally we don't do, we just see a 6th nerve palsy or a 4th nerve palsy or a 3rd nerve palsy, but we don't do a diplopia chatting. It's a very simple test which can be done easily at your clinic. So what you have to do is make the patient sit comfortably, and the head posture should be corrected. The head should be kept straight, and make them wear a red-green glasses, red in front of the right eye and green in front of the left eye, and at 50 centimeters distance you make the patient sit and produce a thin slit of light. If it's a horizontal separation, put a vertical thin slit. If it's a vertical separation, put a horizontal thin slit, and look for diplopia chatting in all 9 diagnostic positions. You put the light and see how much of separation is happening. The maximum separation occurs at the nerve palsy, direction of the nerve palsy. So this is a simple test which we can do it at clinic. So coming to the 3rd nerve. So all of us know the 3rd nerve arises at the midbrain, at the level of the superior colliculus. There are paired and unpaired nucleus. The paired nucleus supply the superior rectus, inferior oblique and medial rectus. So obviously the superior rectus alone supplies the opposite side, and the unpaired nucleus is the LPS which supplies a bilateral LPS, and it passes through the midbrain and the cerebral peduncle. So usually the fascicular part is associated with a neurological condition, and the basilar part, between this to this is the basilar part. This is where an isolated 3rd nerve palsy is very, very common to have. So in this, it passes through the superior cerebellar artery and posterior cerebral artery, lateral to and parallel with the posterior communicating artery, and it ascends forward and enters into the cavernous sinus by piercing through the dura mater and occupies the lateral wall of the cavernous sinus. It occupies the lateral wall of the cavernous sinus, and in the anterior portion of the cavernous sinus, it divides into the superior and the inferior division, and passes through the superior orbital fissure through the annulus of the Zen to supply the respective muscles. So what happens in a 3rd nerve palsy? The patient will have a ptosis. It could be a complete ptosis or a partial ptosis, depending on whether it's a paresis or a complete palsy. The eyeball will be down and out. Adduction, elevation and depression are limited or absent. Cross diplopia and diplopia chatting after lifting the drooping lids. Obviously you have to lift the drooping lids, otherwise the patient is not going to complain of diplopia. And whether the pupil is involved or spared. Pupillary involvement happens in cases of a surgical 3rd nerve, because the pupillary fibers are located superficially and is supplied by the pile plexus. If there is a tumor or an aneurysm which is compressing on the 3rd nerve, these pile blood vessels are affected and the pupillary fibers are affected, and hence the pupil gets involved. In case of ischemic 3rd nerve, the vasa nervosum, that's within the blood vessels, you have within the nerve you have small blood vessels which supply the nerve. These small blood vessels are affected in case of ischemic, and hence the pupillary fibers are spared in case of a ischemic condition. So this is a case of a 3rd nerve. You can see a video. The patient has got a complete ptosis. On lifting the lid, the eyeball is down and out. Abduction is fully present. while adduction is limited, elevation is limited, and depression was also limited. This was a case of a third nerve palsy. So in a case of third nerve palsy, always look for fourth nerve. Our abduction was easy to check. So immediately we checked the abduction and we said yes, sixth nerve is intact. How do you know that the fourth nerve is intact? Ask the patient to look towards the nose and look at a conjunctival blood vessel for intorsion, the movement of the conjunctival blood vessels. If the conjunctival blood vessels move inwards, then you know that the fourth nerve is intact in a case of a third nerve palsy. And always look for misdirection syndrome. The misdirection syndrome, we think that is not very common, but actually it's very common. You have to look for misdirection syndromes. So what is misdirection syndrome? When the nerves regenerate, there could be a misdirection within the nerve itself. So it could lead on to a pupil gaze dyskinesis, which is a pseudo-Robertson pupil or pupillary constriction on down gaze. Keep looking at the pupil. I don't know whether you are able to appreciate it. Look at the pupil. When the patient looks down, the pupillary constriction occurs, and when he looks to the straight, the pupillary dilatation happens. Constriction and then the dilatation. This is pupil gaze dyskinesis. This is one other case of a third nerve misdirection. You can see there is a partial ptosis. The patient is abducting, no issues. When the patient is trying to adduct, you can see there is widening of the palpebral fissure, which is called as inverse duance. And looking down, there is a lid lag, which is called as a pseudo-wanderaphase. So this is one other case of a third nerve misdirection. So now you know that the third nerve misdirection is not very uncommon. So you have to look. Look, when the patient is trying to adduct, there is a widening of the palpebral fissure. Trying to adduct? Yes, widening of the palpebral fissure, which is an inverse duance. And on looking down, there is a pseudo-wanderaphase. There is a lid lag on looking down. See, there is a lid lag. So management. So we now know that this is a case of a third nerve palsy. How are you going to go about the patient? So if the patient is above the age of 50, obviously you are asking for a history of diabetes or hypertension. Even though the patient denies a history of a hypertension or a diabetes, please do glycosylated hemoglobin, fasting and postprandial blood sugars and BP. Because so many times we diagnose diabetes and hypertension when the patient is in our clinic with a nerve palsy. Apart from that, do a diplopia charting and hair charting if you have. Follow the patient after 1 week. Why 1 week is very, very important is sometimes pupillary involvement need not be there at the time of presentation. You assume that to be a medical third nerve, but after 1 week or 10 days, the patient's pupil can get involved. So especially in a case of a third nerve palsy, call them back after 1 week to 10 days to look at the pupil for pupillary involvement. If there is no pupillary involvement, call the patient on a monthly basis for a review to see how the patient is progressing. So when will you image? When will you do an imaging in a case of a third nerve palsy? When there is no history of diabetes mellitus, hypertension or GCA, that is obviously on ruling out your blood sugars and other things, everything is normal, but the patient has got a nerve palsy. If there is a pupil involving third nerve palsy, or if there is no improvement in an ischemic condition after 3 months of treatment, 3 months you've been following up the patient and there has been nil improvement in the nerve palsy or any other cranial nerve involvement associated with the third nerve palsy and third nerve misdirection, apart from congenital cases, you have to do an imaging. These are the indications for imaging in a third nerve palsy. So what are the differential diagnoses? So obviously you have to rule out myasthenia gravis. In myasthenia gravis, obviously variability will be there and fatigability is going to be there. So this history will clinch you the diagnosis of myasthenia gravis, but even then sometimes the patient doesn't give you a proper history. Do an ice pack test for ptosis, and within 2 minutes if there is an improvement with an ice pack, obviously you know that this is a case of a myasthenia. And apart from that, for diplopia, you can do a diplopia charting before and after the hydrophonium test to see an improvement in the diplopia charting. That will help you in the diagnosis of myasthenia gravis. In CPO, there could be a bilateral ptosis, and bilateral, all extraocular movements will be affected, including abduction. So it's just not adduction alone and elevation depression. Abduction is also involved in the case of a CPEO. And idiopathic orbital inflammatory disorder, obviously the patient will have a proptosis, congestion, and all other extraocular movements also can be involved. In thyroid eye disease, again, there is going to be a lid retraction instead of a ptosis, and the muscles will be involved. The most common muscles which are involved are the medial rectus and the inferior rectus. And if you are doubtful, you can do an FTT and confirm it. So coming to the fourth nerve palsy. Fourth nerve palsy, basically it is also at the level of the middle midbrain, below the third nerve nucleus, and it passes through the, it passes around the aqueductal gray and crosses at the anterior medullary velum. This is where a bilateral third nerve palsy is very, very common, because at the point of decussation, when there is a head trauma, a bilateral fourth nerve palsy can happen. And it then emerges and passes along with the third nerve into the cavernous sinus, lies below the third nerve in the cavernous sinus, and into the superior orbital fissure. In the superior orbital fissure, it occupies the lateral portion of the superior orbital fissure, not within the annulus of the Zinn, and supplies the superior oblique muscle. So the right nucleus supplies the left superior oblique because of the decussation. So what will you see in a fourth nerve palsy? So the patient is going to have a head tilt or a chin down position. One eye is higher than the other in a primary gaze. You have to do, when you see a R over L or L over R, you are going to do a pass 3-step procedure. And to find out whether it's a congenital fourth nerve which has gone in for a decompensation, you have to ask for a FAT scan. What is FAT scan? Family album tomography. So obviously you look into the older photographs to see whether the patient has got a head tilt, what it is. We can see from the album. And then you have to look at the vertical fusion. So vertical fusion in a normal person will be only 3 to 5 prism diopters, beyond which the patient will be having double vision. So in cases of fourth nerve palsy, by a congenital fourth nerve, the patient will be able to fuse a very large, up to 10 prism diopters, they will be able to have a fusion. So this is a case of a fourth nerve palsy. You can see there is an R over L. There is a right is hypertrophic and the left is hypo. See, on covering, the eyeball is moving up to take up the fixation. You can see very well the eyeball is moving up to take up the fixation. So you do a dextroversion and a levoversion, and then you do a head tilt. So these are the Parkes 3-step. You can see there is an R over L in this also, very well appreciated. So this is a case of a right superior oblique palsy. So what is the Parkes 3-step? So basically it's a very, when you are seeing the patient, it's very difficult to understand. So that's why I put a Parkes 3-step also. So there are 8 muscles which are involved in the elevation and depression. So these are the elevators and these are the depressors. The obliques act as an elevator or depressor when it is adducted, and when it is abducted, the recti act well as an elevator and a depressor. So always check the oblique in the adducted state, and in the abducted state is the recti. So either if there is an R over L, either the depressors are at fault or the elevators are at fault. So from 8 muscles, even in the primary position, we are able to cut down to 4 muscles. Once you have cut down to 4 muscles, the next step is ask the patient to do a dextroversion and a levoversion, based on whether on dextroversion it is more or levoversion it is more. In this case, in the levoversion there was an L over R. So obviously from 4 muscles we have cut down to 2 muscles, either the superior oblique or the superior rectus of this size involved. So to the opposite side, it's always the superiors which is involved. Then the third step. So you do a head tilt to the right and a head tilt to the left. When you do a head tilt to the right, the eye is intorted, right? So when the eye is intorted and the superior oblique is not functioning well, the superior rectus overacts, and hence you have a superior oblique. When the head tilt is on the same side, it's the oblique. So what are the special features of a bilateral fourth nerve palsy? The patient will have a chin down head posture, reversing hyperdeviation. There will be an R over L on levoversion, and there will be an L over R on dextroversion. X cyclotorsion of more than 10 degrees. There could be a V pattern and downward movement limitation on adducted state. So normally the fovea is 0.3 mm lower than the center of the disc. In cases of fourth nerve palsy, because of the X cyclotorsion, it can be much lower. So again, what are the differential diagnoses? Myasthenia gravis, thyroid eye disease, idiopathic orbital inflammatory syndrome. All these we discussed in the third nerve also. Orbital fracture. When there is an orbital fracture also, you can have a problem like this, but orbital fracture is usually associated with enophthalmos, and if you do an FDT, you will be able to differentiate it. So coming to the sixth nerve palsy. Sixth nerve palsy is located at the level of the pons, and close to it is the seventh nerve nucleus, and then it emerges through the pontomedullary junction as in ZUP, and it passes through the Derulus canal, where the petroclinoidal ligament is above and forms the Dorler's canal, and it enters into the cavernous sinus, and in the cavernous sinus, it's within the substance of the cavernous sinus, not on the lateral wall of the cavernous sinus, along with the sympathetic plexus, in which it can be associated with the Horner syndrome if it is involved in the cavernous sinus, and then it emerges through the middle portion of the superior orbital fissure and supplies the lateral rectus. So this is a portion which gets involved in cases of increased intracranial pressure because of the stretching of the nerve along the Dorler's canal, causing bilateral sixth nerve palsy. So in sixth nerve palsy, what are you going to have? The patient is going to have a face turn, because basically the patient doesn't want to have a diplopia. If I have a right sixth nerve palsy, obviously the patient will turn the face towards the right. So uncrossed diplopia, and look at the fundus to rule out papilledema, to rule out false localizing sign. Sixth nerve palsy is pretty easy to diagnose. So this is having a seventh nerve palsy also associated. The patient has got a lag of thalamus, and you can see the deviation of the mouth. And when you are checking for the extraocular movements, the abduction was limited. So again, differential diagnosis is going to be thyroid eye disease, myasthenia gravis, idiopathic orbital inflammatory syndrome, and Duane's retraction syndrome. Duane's retraction syndrome, which can be commonly be missed and assumed that to be a sixth nerve palsy. Even last week I had a referral as a sixth nerve palsy. When I saw the patient, I was asking, do you have a diplopia? The first thing the patient said, no, I don't have a diplopia. Then I asked, since when are you having this issue? I don't know, maybe for quite some time. He doesn't know exactly from when it was. So obviously when you look for the extraocular movements, always look at the narrowing of the palpebral fissure, which can be easily missed. So Duane's retraction syndrome should be thought of as a differential diagnosis in the case of a sixth nerve palsy, and convergent spasm. So we have covered third, fourth and sixth. We'll look into something else also. What is happening in this eye? There is no movement happening. Adduction is not happening, abduction is not happening, no elevation, no depression. So what is happening to this patient? She has got a multiple cranial nerve palsies. So when do you get a multiple cranial nerve palsies? Where is the commonest location? The commonest location being the cavernous sinus or the superior orbital fissure. In the cavernous sinus, usually the third nerve, fourth nerve, ophthalmic division of the trigeminal nerve and the maxillary division of the trigeminal nerve is located, and the abducens nerve. So all these nerves can get involved in case of a cavernous sinus lesion. Or in superior orbital fissure, you have the lacrimal frontal trochlea, and then you have the upper division and the lower division of the oculomotor nerve, abducens nerve and nasociliary nerve. So these are the muscles, nerves which can get involved, and optic nerve also can get involved in cases of a superior orbital fissure, Tolosa-Hunt syndrome. So the causes could be tumors in the cavernous sinus, cavernous fistula, cavernous sinus thrombosis, superior orbital fissure syndrome, orbital apex syndrome. All these can lead on to multiple cranial palsies. Possible locations, obviously we discussed, was the cavernous sinus and the orbital superior orbital fissure or orbit within the orbit, mostly associated with proptosis. Generally they have a proptosis, and along with the third, fourth, sixth nerve, please look for the fifth nerve involvement also. You have to look for the corneal sensation or sensation over the skin. You have to look for, and imaging is a must. Whenever a multiple cranial nerve is involved, you have to do an imaging. So what is the treatment for third, fourth and sixth nerve? So this also could be taken as a combined approach. So the patient has got a diplopia. You don't want the diplopia to happen, so you give a fog glasses. So you are going to give a fog glasses. So fog glasses, basically for adults it's okay. For the children less than 10 years of age, you don't want amblyopia to happen. So if at all, if you're going to give a fog glasses or occlusion, give an alternate occlusion in case of children. And control the systemic conditions. Hypertension and diabetes should be brought under control. And vitamin B12, I generally give a vitamin B12 to the patients so that the patient's recovery is faster. Oral steroids is debatable. Some people do advocate oral steroids. I generally don't give oral steroids to the patients. And treatment of the cause, if assumed that's a space occupying lesion or increased intracranial pressure, first treat the cause. Obviously your third nerve palsy or a sixth nerve palsy is going to become better. And the prism glasses. So whenever the patient has a diplopia and the patient is not able to continue with the patching, or for cosmetic reasons he doesn't want to have a patching, then you can think of prism glasses. Botox injection, this is a temporary measure to prevent the diplopia in the primary position alone, and surgery can be thought of, but surgery usually we wait for at least 6 months for the diplopia to remain the same. It cannot be variable. If it is variable, you have to wait till it is consistently the same for 6 months before you take it for the surgery. Thank you.
Thank you, Dr. Soundari. That was fantastic. I mean, the kind of knowledge that you bring to the table is amazing. before we go to the audience questions, I think there are a few questions or comments that have come from our online guests, which I would want to just get it out of the system. So one of the comments was incomplete third nerve palsy can also to be imaged. That's one comment. But for some questions that came in, when do you plan a corrective?
Incomplete has to be always imaged. It's the complete where you're more sure that it's vascular etiology.
So when do you plan, panelists, any of you can answer this question. When do you plan corrective squint surgery in nerve palsies? How long do you wait?
The minimum period that is said is 3 months, but it's better to wait even up to 6 to 8 months because some of these palsies keep recovering. So, the maximum window period would be 8 months and the minimum window period would be 3 months.
3 months.
Preferably 6 months. I would prefer a 6 months.
So there's two pools of thought, 3 months and 6 months. Audience, any questions from you before I move to the next question? Okay, one question that has come in is, this is a long one. Can you also please discuss the various levels of third, fourth and sixth nerve palsies and enumerate the steps needed to localize the anatomical level of involvement? Nuclear level, fascicular level, emergence of from brainstem, basilar level, cavernous sinus, and
See, if you have
yes.
a multiple, shall I answer?
Yeah, go ahead.
I'll answer the questions. So basically, in case of fascicular lesion, it's always associated with a neurological condition. As it passes through the red nucleus or the cerebral peduncle, usually there is a contralateral hemitremors or contralateral hemiplegia. So that's when we are able to locate, yes, this is at the level of the midbrain, that the patient is at the fascicular level. If it's a nuclear lesion, you will have a complete ptosis and extraocular movements, and contralateral superior rectus can be involved, or there could be a bilateral ptosis if it is present. This could be a definitive nuclear lesion. And in case of a basilar, usually you have an isolated third nerve palsy. And when it comes into the cavernous sinus or into the orbital fissure, you will have multiple cranial nerve palsies. This is how you will locate where the lesion is.
And as far as localizing is concerned, one easy way is, suppose you have a multiple cranial nerve palsy, you still want to know where the localization is. Suppose you have a multiple cranial nerve palsy with the proptosis, you look at superior orbital fissure involvement. If it's a multiple cranial nerve palsy with proptosis with optic nerve involvement, it is at the orbital apex. Suppose you have only multiple cranial nerve palsy, no proptosis, no optic nerve involvement, it is cavernous sinus. Suppose you have multiple cranial nerve palsy with sixth nerve involvement of the opposite side, then it is bilateral cavernous sinus. Suppose you have shall I proceed? Suppose you have variable muscle involvement, you have to think of myasthenia. You have variable but progressive muscle involvement, you have to think of CPEO. Suppose you have multiple cranial nerve palsies like 5th, 7th and 8th, especially 8th nerve involvement, it is CP angle because that is associated with deafness. And if you have 6th and 7th, it is at the petrous bone. Most probably it is a petrositis, that's what we call it as Gardenico syndrome. You have multiple ocular cranial nerve palsies along with other cranial nerves like the 9th, 10th, 11th, 12th. You have to think of meningitis, you have to think of nasopharyngeal carcinomas. If you have an isolated third nerve palsy along with Horner syndrome, you have to think of cavernous sinus. I mean the third nerve in the cavernous sinus.
Fantastic. Thank you, Dr. Manchula.
One more I would add.
Divya, yeah.
Like we have the fifth nerve component also, because fifth nerve it is something different.
Yeah.
So we have this cavernous sinus, superior orbital and orbital apex, no? So cavernous sinus, when it involves more of anterior, you will have only first division, ophthalmic division. When you have a middle, you have the two divisions involved.
Yeah.
Maxillary also will be involved. The posterior, all three divisions involved. So always examine the ophthalmic division, skin evaluation, corneal reflex. Then you go for the skin of the maxillary distribution, go for the jaw jerk also. So this fifth nerve also helps you in localizing the involvement of the nerves.
Dr. Bala, do you have anything to say? Okay. Dr. Bala, order of correction in terms of third nerve palsies, do you go for ptosis or squint? One of the questions that have been asked. Which one do you go? What's the order?
So always it's the squint which we correct first.
So obviously that itself will correct the ptosis to a certain extent.
Yeah, because sometimes there can be pseudotosis also involved. So always we correct the squint first and then we go for ptosis.
So one question was, what mode of imaging do you prefer? CT or MRI? And should orbital sections be included?
It's always MRI, and you have to do it with contrast and fat suppression to get the best.
And
This thing
if you're
and
thinking of aneurysm, CT angio also can be
angiogram
done.
is important. Yeah, CT or MRI angio.
That's
Today MRI angio is also available.
Yeah,
Pupil, do you have a
orbital section should be included. It's an MR angiogram.
Right.
So if it is positive, then you have to refer to a radiologist, interventional radiologist also for your coiling or
So
embolization.
whenever a brain imaging is done, orbits usually come along
Along
with
with
that.
that.
So
very interesting question that's come in? I want to butt in over here. Surgery for congenital third nerve palsies.
congenital third nerve palsy is very rare, but I will talk about acquired third nerve palsy.
Sure, go ahead.
So acquired third nerve palsies, it's actually very difficult. Third nerve is the most difficult of the cranial nerves to actually treat it surgically, because you don't have any muscles left except for your lateral rectus and superior oblique. And superior oblique's functionality or transpositions don't really work too much. So with just one muscle, you just have to bring on all ocular movements. So what we actually attempt at doing is just bringing the eye to primary position. That itself is a big ordeal, even to attempt that. So what I actually do is, I've tried all procedures, periosteal fixation, everything that is possible in the textbooks, but the best results that is obtained is, splitting the lateral rectus into two halves and transposing it to the medial rectus under your superior rectus and inferior rectus. So we also had one case recently, operated. So for this, I need to see the patient freshly. Suppose somebody has operated, most probably what people do is, they do a lateral rectus recession, just a weakening of the lateral rectus, and then they send the patient. Then it's very difficult to do all this. A third nerve palsy should never be treated with a lateral rectus recession. It's always a transposition procedure. Any nerve palsy is for that sake, because you cannot treat an incomitant squint in the same way as you do a comitant squint.
So another question is, can somebody, Pupil, if you can start, kindly tell about the other false localizing signs.
Okay. Like garden ego syndrome, where you have this 8th nerve also involved, 6th nerve together. You have to look for otorrhea, facial pain, and diplopia together. And localizing sign for your papilla edema in the
It's
disc.
asking for false localizing.
Yeah, false
False
localizing.
localizing is a papilla edema sign where you have
Papilla
increased intracranial tension. And uncal herniation in third nerve palsy, it will be there where you can.
Why
do the
it
third
is
nerve
actually
palsy.
called as a false localizing is because you don't know where
Where
the
the
pathology,
lesion
where
is.
the lesion is. That is why it's called. Anything
Shows
in the
up as-
brain
shows
which
up as something.
increases ICP will causes bilateral 6th nerve paresis.
Right.
So
Can somebody stress upon the fluctuating and diurnal variation?
See, in a case of myasthenia, towards the end of the day, the patient will be having more symptoms. In the morning or as soon as they get up from the sleep, it's going to be much better. And towards the end of the day, that's what we check for fatigability when the patient comes to the clinic. You check for the fatigability. So the fatigability itself indicates that the patient has got a variable ptosis. So when you check for fatigability, the patient will not be able to sustain it in the up gaze. The lid will start to droop. So that's what helps us in diagnosis. And children sleep test is the one which we can do. Make the child sleep and wake up. You can easily pick up the myasthenia gravis in children.
Before I go, can we have audience to ask a few questions to the panelists and the speaker? Yes.
I have a doubt. Recently I had a case of which was looking like a CPEO, but the patient had cataract. So we tried to image the patient, and then we proceeded with the cataract surgery. Patient did not have diplopia post-op. But what would be the right modality of handling a case of CPEO, or what? How do you advise us to deal with it?
CPEO is not symptomatic
That's what
actually.
bilateral involvement is there. So usually when there is a bilateral similar kind of an involvement, the patient doesn't have a diplopia. So safely you can go ahead with this thing. And even if you want to lift up the lids in case of a CPEO, usually lift it just above the pupillary margin for them
The
to
best
see
option
well.
would be only to give crutch glasses.
Yeah, otherwise you
Not
have to
to do
take
any
crutch
surgery
glasses
on
for
those
those patients.
But we can proceed with the
Yeah,
cataract, so
because-
that was fine.
Yeah, patient usually doesn't have a diplopia.
Thank you.
Any questions? Audience? Okay. There's been a request to kind of show the Parks test once again, because I think it. Can we switch off the lights?
The part 3 step, the first step is basically you're looking at the 8 muscles which are involved. The first is to find out whether the depressors are involved or the elevators are involved. So if there is an R over L, there is a right hypertropia over the left hypotropia. So what is going to happen? Either the depressors are at fault or the elevators of this side is at fault. So the depressors are the superior oblique and the inferior rectus of this side, or the elevators of this side are the inferior oblique and the superior rectus. So from the first primary position is the first PAX 3 step. So then in the first step you are able to come to a diagnosis to cut down from 8 muscles to 4 muscles. So either the inferior rectus and superior oblique of this side or inferior oblique and superior rectus of the other eye. That's the first step. Second step, from these 4 muscles you want to cut down to 2 muscles. So how do you do? You make the patient do a dextroversion and a levoversion. In this case, on levoversion there is a R over L. So when it is adducted, the oblique is at fault, correct? So when this eye is adducted, so either the superior oblique is at fault and this is abducted, so either the superior rectus is at fault. So from 4 muscles we are cutting down to 2 muscles, either the superior oblique or the superior rectus. So this is a small this thing. When they look to the opposite side, when there is a hyper, then it's a superiors. On the same side you can think of inferiors. So the third step is head tilt to the same side and head tilt to the opposite side. When it is the same side, easy to remember is oblique. When it is to the same side, the oblique is the one which is involved. So this is a PAX 3 step.
Soundari, can I just make it even more simpler? Just put on the first thing. See, when you have to look at part 3 step, you need a paper and a pencil. You cannot actually do it in mind because you are looking at so many muscles and you're deducing it to one muscle. So what the easier way to look at it would be a simpler form of the part test. Just go to the first thing. You don't, okay, no, this is the first one, okay. See, suppose, as she said, this is a right hypertropia. There is superior rectus, inferior oblique, inferior rectus in the other eye. Superior rectus, inferior oblique in the right eye are the elevators, okay. And superior, in the right, suppose there is a right hypertropia, just give me a pointer. If this is a right hypertropia case, isn't it, Soundari?
Yeah, there is a right hypertropia.
Okay. If there is a...
Try to draw like that.
Yeah.
Hope you are able to understand.
Where is the light not coming?
Because even in a clinical scenario, the
Right
hypertropia
one.
is not going to be a significant difference. There will be a very subtle difference which you have to pick
If
up.
there is a right hypertropia, the depressors in the right eye is affected. That is the inferior rectus or the superior oblique, or the elevators in the left eye is affected. It's not working. Inferior oblique or the superior rectus. Now you don't go for the gaze. You do the head tilt first. Okay. So if it's a right hypertropia, this one, no? Okay. If there is a right hypertropia, the depressors in the right eye are superior oblique, inferior rectus, or the elevators in the left eye. The elevators in the left eye is inferior oblique, superior rectus. Don't go for the dextro or levo version. Don't go for the side gaze. Go for the head tilt. That's the second step. The head tilt, what will happen is when you do if the head tilt to the same side, if you get the hypertropia, it is the obliques. If you head tilt to the opposite side, your hypertropia increases, it's the recti. So let's take this case. The head tilt is going to worsen on the right side. So the oblique. So what are the obliques? The superior oblique, the inferior oblique. So it's simple. 2 muscles have come now. Now third step, you do the gaze. So is it the right gaze or the left gaze? So now you think of left gaze, because usually we know that in case of R over L, in fourth nerve palsy, it will increase in opposite gaze. So in left gaze, which muscle acts in the left gaze? Is it the superior oblique or the inferior oblique? Which muscle? Superior oblique. So the answer is superior oblique. So you don't need a paper, you don't need a pencil, you don't deduce from 4 muscles to 1 muscle, you directly deduce from 2 muscles to 1 muscle. So this is an easy way of remembering in a clinical situation, because we don't have the time to sit and deduce it from 8 to 1 muscle.
There was one question. This was asked in somebody's FRCS course. When won't the patient, when won't the patient complain of diplopia in the third nerve palsy? One is complete ptosis.
Yeah.
Second is when vision is very poor in that eye. Any other causes? This is out of the question.
I think these 2 causes would suffice. Otherwise, vision loss and complete ptosis. Otherwise, they'll have.
FRCS course exam.
Sometimes, I will tell you, in third nerve palsy is very tricky. You have the eye just stuck out and down like this. The diplopia is so
So
far
huge.
away, the patient doesn't actually recognize or appreciate the diplopia. It's very easy for the brain to, occlude the second image. Only when you bring it to the midline, then he suddenly says, sometimes, you're not able to. He appreciates diplopia, he is more symptomatic there. So when you're doing these cases for surgery, you have to be very, very, it's very tricky. You cannot make the patient worse. Then he'll be sitting on your neck every day, day in and day out.
So, role of multivitamin injections in ischemic third nerve palsy. How long do you give
More
it?
of a placebo treatment, I would say.
Placebo.
It's more of a placebo treatment, but if the patient is coming to you and you're going to say the patient is going to become alright on its own, he might not be happy. And I feel by giving a B12, you're not going to harm the patient also. So I usually generally give it for 3 months, and weekly injections of 5 weeks I generally give them.
The more thing is vasodilator. I give a complement retard, which is a vasodilator, and that actually enhances your improvement much faster because it improves the perfusion to the nerve. I think that has to be given in patients with ischemic rather than, Neurobion, as Soundari has pointed out, you can definitely give, there's no harm, especially the tablet form is so very simple to take and it's going to help the patients because most of them will be diabetic and B12, B6 will be definitely deficient.
So last question, I think we'll close after this because in the interest of time. How common is viral infection in cranial nerve palsy? I mean, of course.
Viral infections are not very common, but you do get in young, healthy individuals following a viral infection, sixth nerve palsy.
In children, it is very common. I see
Children,
so
young,
many
healthy
children.
individuals.
Young healthy individuals, very common. Any percentage to this or?
Most children who come with sixth nerve palsy, you can
Is a
take a
viral
default, it's most probably a viral demyelinating.
But
And this
always
is one
think about papilledema also.
Yeah, and the thing is, this is one indication where you can give steroids. It really, the course really gets shortened. Post-viral demyelination, steroid is
Any
indicated.
comments from the audience?
I just have a couple of comments to make. In Caucasians, we have to do a CRP to rule out GCA and maybe plan a temporal artery biopsy if we are suspecting GCA. It's very uncommon in our race, but most common in Caucasians. And the second one is neuroophthalmic problems causing neuroophthalmic problems being neurosurgical emergencies would be couple. One would be the third nerve palsy, complete third nerve palsy with a headache. We have to rule out aneurysms. And the second would be Horner's with a neck pain, which could be a vertebral artery dissection. So those would be emergencies that in neuroophthalmic basically.
Thank you so much. Audiences both online and currently present here, thank you very much for being online. Panelists, please thank, great round of applause for the panelists. And very, very important, Dr. Soundari for giving us this amazing talk on neuro-ophthalmology, cranial nerve palsies, 3, 4 and 6. Coming up next, I think, before closing in, I wanted to give you guys an update on October 9th is going to be our next grand rounds. It's going to be on a glaucoma topic. So be ready with your questions and spread the word as much as you want. And thank you very much for being here. I think we'll cut it short now because we need to all head back to our offices also. So thank you. Bye-bye.